Margaret, do you think we should get started, or were you waiting on some people?
It's one. I heard from a few people on this side that they wouldn't make it today, so I think we should just go ahead and begin. You've got a bunch on your side, so that's great.
Sounds great. So we usually begin these by just some quick introductions of everybody in the room. So I guess our side will start. I can start and then we can go around, I guess, since I'm talking. I'm Kristen Schneider. I'm the assistant professor in public health sciences and working with Dr. Winchester and University Park to have the Conversations in Global Health webcast speaker series. And we're very, very happy to have Dr. Holliman here today to talk about Afghanistan and reconstruction in Afghanistan. So thanks. So how about we just go around the room and everyone can kind of quickly say who's here?
Sure. My name is Keen McCollum. I'm a second-year medical student. I'm also in the Army. I'm doing a scholarship to pay for medical school. And I'm interested in global health. So excited to hear what Dr. Holliman has to say.
My name's Lexi Adams. I have the same story. Second year Army HPSP, interested in global health.
I'm Mark Seaton, first-year MPH student.
I'm Louise Albrecht. I'm a nutritionist here, and I'm just interested in global health.
Hi, I'm Shannon Taninga. I'm an administrative coordinator for the graduate program.
And I'm Angela Matarazzo, and I'm also I'm an admin support assistant for the graduate program.
Hello, my name is Sataria Pan. I'm from Thailand, and I'm the EMS fellow and the MPH student. Yep.
I'm Wiki Wong. I'm an associate professor of public health sciences and director of Master of Public Health program.
Well, I guess we'll officially get started. Can you all hear me okay?
Yes.
And see the slide set?
Yes.
Well, hi, I'm Jim Holliman. I was faculty here at Hershey in emergency medicine from 1989 till 2007. And then a new department chair was hired who forced me out. And so at that time, I took the new position with the U.S. military, listed on the slide here as the program manager for the Afghanistan Healthcare Sector Reconstruction Project. This was under the Center for Disaster and Humanitarian Assistance Medicine, which is a subunit under the Uniformed Services University of the Health Sciences, which is the U.S.'s military medical school in Bethesda. And my task given from the military was to develop a prioritized plan to develop healthcare for the Afghan Army and the Afghan National Police Force. So as we're going along in the lecture, I'd like everybody to think how they might have handled this differently, or if they agreed with the prioritized plan that I developed for the military. Because, of course, the two major difficulties with starting this project were the fact that there was virtually no organized healthcare system in Afghanistan, and of course, huge overriding security difficulty issues. Now, a big chunk of Afghanistan down in the south is sort of featureless desert, but it has some beautiful high mountains in the northern part of the country and some areas of relatively good farmland. So it's a varied topography. Here's a satellite view that shows some of the snow-capped higher mountains of the Hindu Kush in the north and the sort of greenish areas of both north and in the south. This is a map showing the major provinces and the major cities within Afghanistan. The national capital, of course, is Kabul here towards the eastern part of the country. And of course, Afghanistan has a number of different ethno-linguistic groups. The two major languages spoken are Dari, which is mainly spoken in the north, but is also used as the semi-official main language for government and the military. Pashto is the main language spoken in the south, and that's actually the biggest ethnic group within Afghanistan, are the Pashtun. And of course, Afghanistan's first president post-conflict was Pashto. And so here's some pictures of some of the different people of Afghanistan. This comes from my 3,000 picture bank that I took in Afghanistan. And of course, some of the ethnic groups are kind of leftover descendants of Alexander the Great, who came through Afghanistan several hundred years BC. The Hazara is the only Shiite group in Afghanistan, and they have unfortunately been subjected to genocide from both the Pashto groups in the south as well as from the Taliban. And then Uzbekistan, of course, is one of the nations bordering Afghanistan to the north, and there are quite a number of Uzbeks in northern Afghanistan. And just some cute kids in Kabul. And everybody remember this picture from the National Geographic? And then she was later found again and has a considerably different sort of aged appearance now. And I thought this was good advice for much of the country. And of course, Afghanistan is the world's major supplier of opium. And that's also where the Taliban and, in an indirect way, ISIS get most of their funding. And I think the management of this problem has really been mismanaged, particularly by the U.S. military, in that it seemed relatively easy to me when I was there for the U.S. military to simply just buy up all the crop. That way the farmers would still be making some money and the source of income for the Taliban would be taken away. But instead, the military seemed to want to concentrate more on destruction of the opium fields, which of course caused a lot of resentment with the farmers, didn't help the economy, and drove a lot of the farmers into the sort of realm of the Taliban. And of course, Afghanistan was one of the most heavily mined countries, particularly during the war with the Soviets there. And this is still a hazard throughout the country, and there are a number of active demining teams operating throughout the country. But it's interesting, did you know that Afghanistan is not the world's most heavily mined country? Do you know which one it is? Any guesses?
Laos.
It's actually Colombia. So there are more landmine injuries in Colombia currently than even in Afghanistan or Southeast Asia. Most the mine clearing projects actually in Cambodia and Laos have been pretty effective, and that is turning into less of a problem for those two countries now, at least. And a good bit of Afghanistan reminded me of rural India, with a lot of the same kind of vehicles and the same atmosphere and the same odors. There's an Afghan convertible. Buzkashi is the national sport where basically it's kind of like playing polo with a dead goat, and is a particularly sort of dangerous sport from an injury standpoint. Here's just another view of Buzkashi. And this is my colleague, Colonel Ihsanullah Azim. He's now been promoted to Brigadier General and is back in Afghanistan. And over at the Carlisle Army War College, they have a program there that I think some of the global health students here might want to get partially involved with, which is each year they have about 80 mid-level to senior officers from militaries that are friendly with the U.S., and they have a training program for these officers in leadership and other aspects of the military. And it's a very, I think, nice, well set up program. And we were involved as sort of the social hosts for this Afghan officer. And people can volunteer to be the social host for people from any one particular different country that's involved in this program. So they cycle about 80 new officers from different militaries each year for this program. And here's Kabul International Airport. And it was always disconcerting to me to receive the military from the message that Dr. Holliman, your team has arrived KIA. Because of course KIA in military parlance means killed in action. There were a bunch of Russian-made helicopters at the airport. And it's been an interesting development as the Afghan Air Force has been built up, that it's got a mix of U.S. machines and Russian designed machines, with the predominance being those of Russian or Eastern European origin. And so when we were starting this project, we looked at the health indicators in the year 2006 in Afghanistan. And of course, these were some of the worst ever reported. A few African countries are at the same level, but Afghanistan was really at the bottom of the United Nations list in terms of health indicators. So very high maternal mortality, very high under 5-year-old child mortality. About half the kids under 5 had malnutrition. About half the population had significant iodine deficiency. Life expectancy, you can see, was about half that of Western Europe and the United States. You might say excessive lifetime births relative to other countries. And the safe water was listed at that time as access at 80% urban, but I think that's really a gross overestimate, that really the access to safe water throughout the country was probably only about 10%, including the urban areas. And in one of the provinces of Afghanistan, the one that has that land peninsula that sort of sticks over to adjoin China, called Badakhshan, in that province at this time, women had a 1 in 3 lifetime chance of dying from complications of pregnancy. Most of the deaths in kids were from diarrhea, respiratory infections, and vaccine-preventable conditions. Tuberculosis is a huge problem there, particularly in women who are more housebound than men. Malaria is actually a big problem in southern Afghanistan. And with global warming, one of the effects that's seen is the range for the Anopheles mosquito is increasing, also into higher areas than before. Narcotic abuse was a huge problem throughout the country. And HIV is thought to be a major problem, but of course there's almost no testing, so there's no verification of that. But this was also a big disease burden in Afghanistan. And unfortunately, Afghanistan has been essentially at war full-time since 1979. So there was a major war with the Russians from 1979 through 1988, then developed a, you might say, a civil multi-factional war from 1988 till 1992. Then the Taliban invaded in 1992, then there was all that further conflict that has essentially remained through today. And unfortunately, a lot of people in wheelchairs from leg injuries and foot injuries from landmines. And Massoud was the leader of the Northern Alliance. And remember, he was assassinated the day before 9/11 as part of the Taliban sort of combined plot. And he's highly regarded throughout Afghanistan. But if you actually look, I think he's got a checkered history in that his forces are responsible for much of the physical destruction of the city of Kabul because of the infighting with the other groups there. And his forces actually carried out a number of massacres of some of the other ethnic groups in Afghanistan. So what were some of the major health system challenges that we had starting this project? Well, there was very little infrastructure for healthcare system in Afghanistan. There was a lack of management skills and technical expertise in the Ministry of Public Health, and at that time, major dependency on the non-government organizations to provide healthcare. And then, of course, there was a lack of data, lack of healthcare system monitoring. Some additional things were, it's you might say, some difficult geography with the mountains in the central part of the country. Very cold winters, particularly in the north. I spent a month there in January, and it was 25 below zero almost all the time, all month long. And then, of course, there's the hot desert, particularly in the south, with extremes of heat in the summer. Security, of course, was a huge problem. The Taliban had forces throughout the country, were particularly strong in the south. The sort of, you might say, new difficult security problem that has developed, and not just in Afghanistan, but also in other countries, is the direct targeting of healthcare personnel and healthcare facilities by the insurgent groups. And so essentially almost anything you'd have to plan for Afghanistan, you would have to budget at least 50% of your budget for security. There's, of course, ethnic and culture diversity in the country, and a lot of the ethnic groups don't get along very well. There was the challenge of balancing the demand for tertiary care with the getting primary care in place before that. And then there was a huge problem with trying to coordinate both Ministry of Public Health, Army, police force, donors, and the NGOs. So here's a map showing the UN coding of security ratings province by province. Green is secure and relatively safe. Yellow is potentially problematic, and pink is dangerous. And essentially any of the areas designated as pink by the UN, UN personnel were not permitted to go there unescorted. And so this made, for instance, the vaccine distribution programs problematic because of the security issues and the actual danger to the healthcare personnel. So that was the situation in 2006. Here's the map for 2007. You can see the pink areas have significantly increased. And 2008, even a further increase, despite the up-tempo of military activity from the US and NATO. The current map is somewhat similar to this. The US actually and UN actually helped write the new constitution of the Islamic Republic of Afghanistan. And this was ratified by the first president, Karzai, in 2004. And one of the provisions of this new constitution was that the government, the national government, should provide free preventive health care and treatment of disease, as well as free medical facilities to all citizens. I think a very sort of bold goal, and obviously difficult to bring about. So what were the components of Afghan healthcare when we started this project? Well, under the Afghan government was the Ministry of Public Health, and this is the main organization responsible for directly delivering and supervising the delivery of healthcare. Then there was the Afghan National Army, which was under the Ministry of Defense, and the Afghan National Police under the Ministry of the Interior. And one difficulty we had was that the Army wanted its own healthcare system, and the police wanted their own healthcare system, not necessarily in coordination with the Ministry of Public Health. Then there were a number of military facilities around the country, with the biggest one being at Bagram Air Base, where there was a nice Air Force-run hospital. Several of the other militaries involved, such as the Czech Republic, also ran hospitals, several of which were mainly for the US and NATO military forces. Then it turns out that despite the poor economy, the Afghan private sector had a thriving, relatively thriving healthcare delivery system involving private physicians, clinics, and offices. And we'll see a difficulty with that a little later on. Then, of course, there were a number of private donor and non-government organization clinics and hospitals. The International Committee of the Red Cross and even CINA ran some clinics. Cure Hospital was run by an NGO. There was a French hospital in Kabul, also run by an NGO. Also hospitals run through German NGOs and Turkish NGOs. So civilian healthcare was, of course, very fragmented, non-integrated. you might say was adequate probably only in Kabul and maybe in the city of Herat. And most of the delivery of healthcare was from the non-government organizations. There was pretty much almost completely undeveloped emergency medical services or pre-hospital care or ambulance care. Trauma care was not at all in place outside of the military hospitals. There was very little training or capability for mass casualty care or for disasters. There was, in some places, basic maternal, basic child care in place, but very spotty in terms of coverage. Minimal mental health. This is a huge problem you'll see a little later on. In the entire country, when we started this project, there was one board-certified psychiatrist. There was essentially zero teenage and child mental health services available. There was one psychiatric hospital that had about 50 beds for the entire country. Minimal public health, even though it was listed as the Ministry of Public Health, they had very little capability to do health supervision and health public health statistical study. So again, a major lack in personnel management, personnel accountability, leadership, and execution. And in fact, one of the secondary projects I was tasked with by the military was to develop a leadership course for the Afghan army and police generals, because none of them had really had any leadership training in the past. So here's the Ministry of Public Health building. This was right near Camp Eggers, and essentially just catty corner across the street from the main NATO base in the center of Kabul. This was the Minister of Health when I started there, Dr. Fademier, one of the few non-corrupt ministers in the Afghan government, and I think was doing a relatively good job with the limited resources he had at that time. And this was the Deputy Minister of Health, Dr. Kakar. He actually had a PhD, I think, in epidemiology from the University of Washington. And this was a map they gave us that showed the alleged position of the Ministry of Public Health clinics that had been established throughout the country. And you can see there's a relatively large number of dots and crosses there on the map. And it turns out probably about half of these were completely imaginary. In other words, there was supposed to be a clinic there, but it wasn't actually there. Or if it was there, it was just a concrete shell. And quite a number of them had been built, but then had, due to weather or flooding, had essentially been destroyed. And so this plethora of what looked like clinics well distributed throughout the country when we started turned out absolutely not to be true. And in fact, the Ministry of Public Health didn't even really know where most of these were. I think I skipped a slide. Now, one good thing that we did have in place, though, that the UN had helped put together were these two healthcare plans that the Ministry of Public Health was tasked with carrying out. So one is called the Essential Package of Hospital Services for Afghanistan. And this was a detailed sort of definition of what exact services and equipment were going to be at each hospital level throughout the country and what medications would be provided. And then the basic package of health services described the, you might say, the primary care that was supposed to be delivered free to all the citizens, particularly maternal and child health. And so in the basic package of health services were the categories of maternal and newborn health, which included family planning, child health and immunizations, public nutrition involving correction of malnutrition, control of tuberculosis and control of malaria. Mental health was listed, although not, you might say, operationally supported. Disability also was listed, but again, not effectively operationally supported. And the supply of essential drugs, particularly vitamins and anti-tuberculosis, anti-malaria meds. And then the basic health facilities that were designated were sort of The first one was the health post, and this would be staffed by a trained community health worker who would see people, distribute meds, and if anybody was sick, he would then refer them up to the next level, which was the basic health center. This would be staffed by one physician or a nurse or another healthcare provider, and be able to provide some basic health services. Then people that may be a little bit sicker or more complicated would be referred to the next level, which was the comprehensive health center. This was staffed by a number of different healthcare personnel and had increased services, and this would be the first level also where dental services might be available. Then the next level up was the district hospital, again staffed by at least several different physicians, a number of nurses, and had at least some limited degree of inpatient management capability. And so there's supposed to be one of these district hospitals in each district or each subunit of each province. And this is a graph showing the sort of hierarchical healthcare system structure. So you have your health post down here at the base level, supposed to be 6,500 of them. Then the basic health centers, of which there were almost 700 theoretically. Then the comprehensive health centers, about 400, 62 district hospitals, 29 provincial hospitals, 6 regional hospitals, and a couple of national level facilities in Kabul. And the essential package of hospital services detailedly defined what was going to be in each one of these different hospitals. As an example, anti-seizure medications were limited to the provincial hospitals and weren't at the district hospital level. And that struck me as potentially dangerous, but they said that the thinking behind this was that the doctors at the district hospital level had never been trained in seizure management or the use of anti-seizure meds, and therefore they weren't going to release them to that level at this time. And then this is sort of a diagram showing the links between the different components of the Afghan healthcare system. So you have your health posts that send people to the basic health centers and the comprehensive health centers that then refer patients to the district hospitals, who might refer patients on with more complicated illnesses to the provincial hospitals, and then the regional or national hospitals in Kabul were sort of the final level. Where did funding for the Ministry of Public Health come from? It was nearly all external funding, since at this time the Afghanistan government was still not making much of its own money, despite having quite a actually fairly rich natural resources that could be tapped. Anyway, so the World Bank, U.S. Agency for International Development, and the European Commission were the 3 major funders. And what the Ministry of Public Health did was contract with different NGOs using these funds from those 3 sources to theoretically execute or carry out the basic package of health services. And so this was done using capitated payments. And then they were also partially dependent on free services that were more or less directly supplied by the World Health Organization, UNICEF, and some of the NGOs. So here's the Children's Hospital, which was right across the street from the main military hospital in Kabul. This hospital was mainly funded through an Indian government NGO. And this was an unfortunate dying child. You can see how malnourished he is, we saw at the hospital there. And this was a child with bad burns. Most of the patients with bad burns did not survive. The only burn unit in the entire country was in the west in Herat. And you can see how crowded the conditions are there, that they would have 2 or 3 kids in each bed. And of course, a number of these mothers have active tuberculosis, and so the infection control at this hospital was not too good. And here's a little kid that was going to be operated on later that day. And you can see he's got distal necrosis from sepsis. And they got the sepsis under control, but unfortunately was left with this damage to his extremity. And the nursery was also so crowded that it would typically put 2 kids in each bassinet. And this was the clinic waiting area at the Children's Hospital. Crowded and very busy. This was Cure International Hospital in southern Kabul. This was operated by an NGO and provided some high quality, I think, reasonably high quality healthcare. Also had the only functioning pathology laboratory in the entire country. And unfortunately, a number of the people that I met and worked with there were murdered a couple of years ago. Here's the only pathology lab in the entire country. This was operated by a Canadian. On one of our trips out of Kabul, we went down to this city of Gardez, which is near the Pakistan border, and visited the regional hospital there that was run under the Ministry of Public Health. This was a typical ward room in the hospital. They have so much eclampsia there, they have a whole ward just for that. This was the emergency room, and this was it. This was all the equipment they had. And this was the emergency room to service a population probably total of about 300,000 in the city and region. Another huge problem in Afghanistan is the deforestation that has happened. Here's a truck full of firewood, and there's been, essentially, as far as I know, still no plans to try and reforest the country, as was done, you might say, very successfully, for example, in Israel, and very successfully in Korea. And it's something that really needs to be done, I think, for Afghanistan. You can still see camel caravans there. This is at Rabia Balki Hospital, which is one of the 2 main large women's hospitals in Kabul. And they have so many abandoned newborns that they have a set-up place for taking care of those kids. This was sort of a made-up graph about their maternal mortality, and you can see the trend is downward. It turns out, though, that when we looked more carefully, these were doctored statistics. And this was their neonatal mortality. And again, these turn out to be doctored statistics. Infection rates also doctored and actually much higher than this. And then this is the other women's hospital, Malalai Hospital, that was mainly supported by a US-based, church-based NGO. And one of the projects I'm most proud of in connection with my project in Afghanistan was we put together the first ever postgraduate training program for the women obstetricians at this hospital, and got them extra training from 2 US experienced obstetricians. And as a result of that, we got the maternal mortality at this hospital that does 100 deliveries a day down to 0 over 6 months. And we only had 2 neonatal deaths after this training project. And so it's one of the things I feel was a big successful component of the project that I was involved with. This is a patient care area in the hospital. It's my colleague there, Colonel Woods, in the foreground. Water damage to the ceiling. The Baby Friendly Hospital Initiative is a UN categorized designation that if you meet certain criteria, you can be designated a baby friendly hospital, and this hospital was. They proudly showed me their lab, but it turns out the lab was completely non-functional due to lack of reagents. So one of the major projects we got involved in was trying to improve the lab reagent supply, both to this hospital as well as to the military and police hospitals. It was a huge problem throughout the country of having non-functional lab services. And their delivery suites, though, I thought were pretty well arranged and pretty well equipped. And family planning and birth spacing are actually starting to be accepted and supported across the country. And of course, there's a huge need for that. And turns out, of course, there are no true religious proscriptions against this in the country. This is Kabul Medical University. There are 8 different medical universities throughout the country, but this is the main one, and certainly you might say has the highest quality for training and resources. Loma Linda has been one of the supporters of Kabul Medical University. This was my original team meeting with the chancellor of the university. We ended up supplying the university with a large number of training materials and also a number of computers. Unfortunately, the medical school was in the crossfire during the Civil War and still has some RPG hit marks on one of the school buildings. And one of the school buildings kind of out back of the main building you can see has been essentially gutted in the fighting and not restored. Now we shift over to the National Military Hospital in Kabul. The guy on the far left was the Afghan Surgeon General at the time and his senior leaders. And it was also good to see that there was some female leadership within the Afghan army. The person in the center there is a brigadier general who's actually in charge of the nursing corps. And next to her, the person in the white gown is one of the most famous surgeons in Afghanistan and was the only female surgeon allowed to continue operating during the Taliban occupation. And the ANSF, or Afghan National Security Forces, which was a designation that includes both the Army and the National Police Force. These were their major medical facilities. So you can see up north in the city of Mazar Sharif was a 50-bed hospital. In Kabul was the main hospital, the 400-bed National Military Hospital, and also the ANP, or Afghan National Police Clinic, which actually turned into a hospital. Then in Gardez, there was a 50-bed hospital. In Kandahar, a 50-bed hospital. And in Herat, a 50-bed hospital. So in each of the 4 designated military regions of the country, we had built for them a 50-bed hospital, mainly for the Army. And this is the National Military Hospital in Kabul. It's one of the few good things that was built during the Soviet occupation. And I think part of the reason for that was it wasn't designed or built by the Soviets, but it was actually designed by an Italian and built with Italian-based money. And then right next to the hospital is the National Military Training Center that was set up to train military medics. And they actually had some pretty good training equipment for the medic training program. And here's one of their classes. And what they did was conduct the entire training program in the language of Dari, and then they would have the same class go through the same training again in Pashto. And the idea was to encourage more interaction between the 2 different ethnic and linguistic groups. And the Army was trying to, you might say, sort of integrate itself across the different ethnic groups. This is the training base clinic for the Afghan National Army. And this is where all the recruits would come for their initial health screenings when they were enlisted in the Army. And as is typical of most of the Afghan health facilities that we saw, they had some really nice medical equipment, but didn't know how to use it. And so you can see here a bunch of the nice equipment they have is under wraps because they don't know how to use it. And another problem we found was, a major problem was that a lot of the equipment might be broken and they didn't know how to fix it. And so here we are on one of our trips out to the hospital in Gardez. And we had a nice sort of royal luncheon there. And this was one of my colleagues who's a critical care physician on my team, and they had this young soldier in the hospital for several weeks because of this abnormal chest X-ray, and they didn't really know what to do with him. And it turns out it was just a fibrothorax, and so we told them that they should send him back to duty. And this, they had a very nice ultrasound machine, but nobody there knew how to use it. And this was the staff meeting we had with trying to organize the relatively new medical staff for this hospital. And then another thing that we got going later on was that there was designated to be the National Military Academy with the National Military, you might say, Medical School. And so the students for this, this was the first class, and we were pleased that they also selected some women for this. And basically, they would spend their first year at the National Military Academy of Afghanistan and then be integrated into the medical school at Kabul Medical University. This was the then subsequent source for the military physicians for the Afghan Army. And now we'll shift to talk about the Afghan National Police. Basically, when we started this project, they had 60 trained medics that were trained in the equivalent program to the Army's medic program. And you can see the way they divided up their administration was through these 5 different regions. And we met with the Afghan National Police Surgeon General. This guy was an ENT physician and was very difficult to deal with, and that he wanted a completely separate, independent healthcare system for the police. And of course, since the police were scattered all over the country, and most of their healthcare was going to have to come through the civilian healthcare system, one of the difficulties I had was convincing the military that we had to work on integrating with and directly supporting the civilian healthcare system if our mission was to improve healthcare for the police. And the police actually had a very nice training academy in Kabul. Here's one of the classes training outside. And they had a nice dental clinic there. And this was supposed to be their polyclinic, but they essentially converted it into a hospital because they didn't want to be dependent on the Army for inpatient care. Unfortunately, whoever designed this forgot to put a kitchen in it. So this was the outdoor kitchen, and since it was 25 below zero, it was painful to have the staff cook and then bring stuff back into the hospital. They had some good equipment inside, though, good otoscope, ophthalmoscope. This was the so-called obstetrics ward, which basically consisted of these 3 beds. And we tried to convince them that they really needed to have all the obstetric services shifted over to the 2 women's hospitals where there was real expertise, as opposed to here where there wasn't. One other major deficiency in that hospital was they forgot to put an elevator in it. And since they had most of their sick patients on the 2nd floor, they had to be hand carried up the stairs to the patient care rooms. This was an isolated police station, and this was sort of a demonstration of why the police are so vulnerable to being attacked by the Taliban, because there might be 6 or 8 police officers at this station for which there's really nothing for miles on either side of it. And they occupy these very isolated facilities. The International Security Assistance Force was the, you might say, the broader name for the military force that was originally from NATO, but since it involved a number of countries like Australia that are not members of NATO, it was kind of renamed the International Security Assistance Force, and was responsible for providing both military support and some indirect health care throughout the country. ISAF, though also from the American side, we thought stands for I Sit, Americans Fight, or I Spend American Funds. And a number of so-called provincial reconstruction teams were designated to be under the different ISAF country militaries and throughout the country. And the purpose of these provincial reconstruction teams was to coordinate both reconstruction of the general economy, local facilities, and as kind of a side goal to support or reconstruct healthcare facilities. And so here's a couple of the PRT bases. This was ISAF headquarters in Kabul. It was much cushier than the US base. They even had their own carpet shops on the base. So here's the plan that I came up with, the so-called program management plan for the military with, you might say, ranked priorities. So this is what I want you all to think if you might agree with this. So the first was to integrate healthcare services across the Army, police force, and the Ministry of Public Health, rather than have separate development as completely separate healthcare systems. Then the next priority was to create training programs for medical logisticians and biomedical equipment repair. And you might say, well, Jim, now wait a minute, isn't maternal and child health more important than that? Well, we thought this was actually a higher priority because by doing those two training programs and getting those in place, the improved medical logistics and improved use of medical equipment would directly affect maternal and child health. So then we put maternal and child health next, trauma and emergency medicine fourth, building more collaborative relationships, particularly between the agencies and the NGOs and the private sector. Then six, as a civilian, I told the military they need to straighten out their command structure in Afghanistan. Of course, they didn't pay any attention to that, but they had a very convoluted command structure that made things difficult. And then number seven was, because the security was so bad throughout the country, was to utilize military personnel directly for a lot of healthcare development efforts, and also in providing security for a number of the more isolated healthcare facilities. And then using improved healthcare as a measure for counterinsurgency. And so here's the priority sequence that I came up with for this plan. First was to integrate the security forces healthcare with the Ministry of Public Health, then fix medical logistics because supply of health equipment and medications, and as I said, like lab reagents was so bad, then generate biomedical equipment repair, then maternal and child health, trauma and emergency medicine, mental health came in next, construction of new healthcare facilities came next because a number of them had already been constructed and could be utilized, so we put that lower down on the list. Then develop hospital administrators because they really had hardly any trained hospital administrators throughout the country. Rehabilitation and therapy services came next, then anesthesia, then optometry and ophthalmology services. Turns out optometry actually had a direct military bearing in that there were so many people with bad eyesight that they improved their shooting ability once they got glasses. Next came family medicine, which was essentially unknown at the time in Afghanistan, then occupational and preventive medicine, the other allied health fields, dental and veterinary. Again, I told them to restructure the medical command. Then disaster and multi-casualty response, then IT and medical communication systems. And then this makes some of my public health colleagues upset, but I put public health surveillance low down on the list. And that's not to say it's not important, but I felt that in a situation where you don't have actual healthcare delivery, that you need to put in healthcare delivery before you can monitor its effects. And then pandemic response was last on the list, but in there. Of course, at this time, there was great worry about the spread of avian flu to Afghanistan. And the military likes flow charts. So this is the flow chart I developed of how this is all supposed to work. So you have your revenue coming in at the top, coordinated financing, that goes to the Ministry of Public Health and the Afghan National Security Forces. They obtain equipment and facilities, educate the staff, and then all that comes down to improving healthcare delivery, which also affects national security and support of the government. Here's the ruins of Darulaman Palace in South Kabul. It's still got some mines in it. It has not been restored. And it's really sad because this used to be just as beautiful as any one of the, say, major palaces in Vienna. And I didn't realize it at the time, but I actually met the heroine of the movie Zero Dark 30. And she was a CIA operative and was out with us at these refugee camp visits that we were doing. I was wondering, what was she doing out here? Risking being out with us at these refugee camps. And as you saw in the movie, here she was questioning the refugees for information that might lead back to where we could find bin Laden. And this was a cute refugee kid at one of the camps that gave us the thumbs up. Okay, so that's my presentation on the project in Afghanistan that's still ongoing. And one way to think about it is if you get involved with some of the other countries that have very poor health system structures as to where you would start in trying to help improve their healthcare system. And I think this sequence or this model is applicable to a number of other countries. And in fact, the Africa Command has used this in making development recommendations in some of the African countries. So thanks for everybody's attention. Are there any questions or comments? Yeah.
Where did you, where was it that you came up with this this structure in which you gave them the list back, and how did you decide on which one should be first and which one should be last?
It was through a cram study that I did on Afghanistan, because I admittedly didn't know that much about Afghanistan when I started this, as well as our site visits all over the country. And then of course I had a team assigned to me of senior military leaders that were came from different backgrounds. And so this plan I didn't put together by myself, but my team was responsible for this. And so we basically made it all up based on our own study. Yeah.
So some of the one of the lists on the top of your list, I think number 2 is to really create an infrastructures to repairs a medical device and supply. I thought that was a very, very interesting idea. But one thing that I thought about also is that many of those medical supplies and device, I would imagine, is probably by donate or donations or coming from all over the place in the US and German, Japan. How do I'm just imagine that our hospital personnel can even fix our own equipment. That depends on the vendor. So
well,
how do we do that?
You're right. We were recommending the sort of new process that any equipment that was donated had to be donated with a resupply and maintenance tail, because that didn't exist before. So we felt that if we could get a bunch of people trained to go around to the different facilities and just fix the existing stuff that they had, that would improve the situation greatly. But for the future use, any contracts would have to have a maintenance and supply tail. As an example of how this got sort of, you might say, goofed up, was the Army was demanding for a long time that we buy them, the U.S. military buy them an MRI scanner for that National Military Hospital, and the U.S. military refused because there was nobody in the country that knew how to read MRI scans. So the Germans knuckled under, though, and bought it for the National Military Hospital. So the first day that they had the MRI scanner operational, a soldier walked in there with his M16. Of course, the magnet grabbed his M16 and it wrecked the magnet. And now they had to spend another couple $100,000 to fix the thing, which still nobody knew how to read the images that would be generated anyway. And so that was a huge waste of money. And it was a big problem that we were under all this pressure from the Army and the police force to do things kind of, you might say, the tertiary healthcare delivery level, when they didn't even have basic care or basic trauma care or basic emergency care in place. And of course, I thought that was a lot more important to develop and not jump right to these more showy tertiary services.
Right. Good point.
I had a quick question on our side. Thank you so much for your presentation. You spoke a little bit about the different ethnic differences in the country and some of the conflicts from that. I was wondering how that's being addressed in the new healthcare system. You mentioned some of the trainings being done in multiple languages, but have there been any other efforts to address that in rebuilding the system?
Well, yeah, the Army and police force, I think, are doing a relatively good job of trying to change the philosophy to where there's more of a national focus and not so much of a tribal focus for each person, and that they, in the Army and the police force, learn to work together and get along. And I think there's been some success with that. And then using that as a model for the rest of the population, that all these people should just get along and focus more kind of at the national level rather than at the tribal level. So there has been, I think, some positive motion in that direction, led by the Army and police force.
Thanks. I think that's it from our side. Any other questions from yours?
So in your interaction during the time at Afghanistan, did you perceive that you received that the local are willing to take up and pick up their efforts and to improve their healthcare delivery system? Or
Yes. Well, that was one nice positive thing, that most, particularly of the younger people we work with, both in the Army and the police force and in the civilian facilities, were very anxious to cooperate with the U.S. and ISAF and improve healthcare for their own country, their own citizens. Now, there's also kind of, you might say, the residual communism that's left at a lot of the senior levels in the country for people that were sort of leaders during the Soviet occupation time. And there's still that element of you might say, the communist effect of not wanting to stick your neck out, not wanting to develop new things, and just wanting to sort of boss people around without getting anything done. So there is, unfortunately, that element is still extant at a number of different levels in the government. But the bulk of the people I work with were all very cooperative and interested, had the same goals as we did in terms of trying to improve the healthcare system.
Right. And I think that one of the biggest challenges, I think, that international development is to come up with this PMP that with a very specific goal that when everything is said and done, that we hand it over to the local, and they will be able to pick it up and be able to implement it. And I think that it is probably the biggest challenges in any international development. And I wonder if that kind of a thought has been factored into the process and thought process as you interact with your colleagues there.
Well, yeah, that's why we focus so much on training, feeling that once people were trained, then they could do this themselves. Then the other key aspect to really make this happen in a broad sense is for Afghanistan to develop sources of revenue. Because right now, their main source of revenue, you might say, is just the taxation that they have on transportation that comes from other countries into Afghanistan. But they have huge mineral resources, it turns out, and actually a fair amount of oil. And so if those can be developed, and of course, the difficulty with getting that source of income developed is the bad security situation. But it turns out that hopefully long-term, once they can get those sources of income developed, then they will become independent of all the foreign money that has supported them so far. And we did have that as sort of the tail end of our plan, was the concept that this should all be turned over to the Afghans. They should be operating this themselves, and they should be funding it themselves as the end point.
Right. Okay. Very fascinating.
Great, thank you so much. We have to wrap up on our end for the room, but I hope you all can join us again in 2 weeks when Stephen Matthews presents about urbanization and migration in Southern Africa. And thank you again, Dr. Holliman, for your presentation. We really enjoyed it.
You bet. Thanks, everybody, for your attention.
Yes, thank you very much for coming. This was wonderful.
Thank you.
Thank you.
Thank you, Dr. Holliman.
You bet.
This is fascinating.
And then I think